serial growth where you're seeing that the graphs are beginning to show a tailing of growth, or you've got a pattern where you're just seeing the birth weight and we are taking the outcome as a low birth weight. So in terms of the demographics, this is what Dr. Subha wanted to share with us. What would you like to say, Dr. Subha?
This was actually a paper by Dr. Butt and his group from JIPMER, which showed us that in the last, this was from the 1990 to 2006 data of low birth weights in our country. He was trying to point out that there was not a huge drop in low birth weight numbers in the last, that period. So what kind of measures we can take to show a dramatic drop in low birth weights, which can actually decrease mortality and morbidity in them also, because if they achieve adequate, they get proper care postnatally too. So this was from that study. So
we have a big problem because in terms of percentages, it's quite a big number that has been projected. Dr. Shajit, this is the trends that you have shared with us at your institution. And when we talk of well over 2,000 low birth weights in a year, it is a huge task to actually be able to look after them. Over the years, while you've been there, though there is a trend that we can see, how has it been for you clinically? Are you feeling the load is getting lighter and something is improving, or it is not as evident as the graph?
So actually, we have around 15,000 to 18,000 deliveries per year at IOG. And among them, we are seeing around, like in 2018, we had 3,000 low birth weight babies. That is including both preterms as well as SGA babies. So this constitutes around 20%. So though, and that over the time in 2019 and 2020, we can see that it is slowly coming down. So now it is something hovering around 2,500. So that makes a percentage of around, say, 20%. So though we are well below the national 30% that we are looking at, but still this is a huge number when we deal with these babies at the IOG. You know, this constitutes a very huge number. So we still feel that though we are giving like things like progesterone supplementation, antibiotic prophylaxis, and aspirin prophylaxis, though we are doing cerclage and tocolysis to reduce this low birth weight number, but still I think we need to improve upon this maneuvers and techniques so that we can come down drastically. As Dr. Subha was also telling, we are a little, we are gradually coming down. We have to implement certain techniques that we come down on this number drastically as far as possible to avoid the morbidities and mortalities in this group.
Thank you, Dr. Shajit. At our institution, we took our definition of a small for gestational age at a term, and we took it based on gestation because we went by the centiles based on each gestation. So we did not use a 2.5 cutoff. And to understand what was growth restriction in our population, we just wanted to see what was our weight distribution. And we found that at term, our babies weighed between 2.3 to 4.1 kg, with the mean, mode, and median being 3.2 kg. And when we looked at twin pregnancy, because that is a high-risk group where growth restriction is a problem, we found the mean weight was around 2.5, and we spoke about term deliveries. Whereas if you looked at the population and we compared singleton and twin, and the only reason I put twin is I didn't want that to make the data appear to have a different level of SGA. Singletons had a 6% small for gestational age, whereas in our twins, we had a 10%. And the problem of prematurity, because we looked at gestation-based cutoffs for weight, is that we have a preterm and small for gestational age happening in 3% of our singletons, whereas it happened only in 40% of our twins. So that is also one of the ways to look at it. But in a universal term, I think taking a single value and using that as a cutoff gives us better data. Dr. Subha, what do you think is the importance? Why are we now so keen on this 2.5 kg, and why do we want to discuss this to reduce the outcome? Is there a reason? We know from the INAP report that a lot of births occur in India because we are a big country. But more than that, we know that a lot of deaths are also occurring, and there is a lot of importance from the Millennium Development Goals, which have helped outcomes to improve. but we have a 27% newborn mortality in our country. And there is a lot of work because a lot of this is happening within the first 1 week. So, what do you think is contributing to the perinatal and long-term morbidity? Subha, your mic is on mute.
As Dr. Sajid was pointing out, the increased mortality and morbidity for that particular weight is definitely high, because these neonates, fetuses have already gone through in utero hypoxia. So they have already had a lot of nutritional deficiencies, and which because of this, they can have a lot of postnatal implications. So, so they do have a lot of problems in the immediate neonatal period. Plus, they have a lot of problems in the long-term effects also in these babies. So that is why we're talking about how to reduce having low birth weight babies. So the immediate implications are, because they are hypoxic in utero itself, they can have a higher chance of asphyxia at birth. So it's better to be delivered in a setup where they have a good neonatal care, where they can have a personnel who can do proper NRP and prevent asphyxia in these babies. Other biggest issue will be temperature maintenance right from the delivery room. So hypothermia is a big killer, all of us know, because these babies are deprived of subcutaneous fat because of all the nutritional deprivation in utero. Temperature maintenance, if it is not in a good healthcare facility, becomes a big issue with these babies. So starting after that, coming to the neonatal NICU or intensive care for these babies, because of lack of glycogen stores, they can have glucose issues. Compared to our big gestational IDM babies, these babies have prolonged hypoglycemia. They have hypoglycemia starting after the 4 to 6 hours because they have very little glycogen stores which can keep them okay for the first few hours. And then they start becoming hypoglycemic, which lasts for about 5 to 7 days too for some IUGR babies. So those needs very, very stringent monitoring, because we know hypoglycemia can cause brain injuries, and that can also affect long-term neurodevelopmental outcome. Calcium issues, just like preterms, which needs monitoring, and polycythemia. Because of all the in utero hypoxia, they have polycythemia. Polycythemia can cause a lot of other complications, all of us know. They can have sludging circulations in all different organs of the body, which can be the biggest reason why these babies are more prone for NECs. So early breastfeeding and exclusively breast milk for these babies, especially babies who have Doppler abnormalities, which are a big chunk of babies who are IUGR. Then these are the immediate problems which we face, and polycythemia can also cause bilirubin problems, jaundice issues, and renal vein thrombosis. So there are a lot of perinatal as well as early neonatal problems in these babies which have to be intensely monitored and attended to. Long-term implications is they are small for birth, as Dr. Shajit pointed out. They can be less than 10 centile, and we always talk about these symmetrical and asymmetrical babies, which have all their anthropometries down. So they are going to be smaller. So stunted meaning weight can be low, height can be low, head circumference can also be low, so microcephaly. So all these have to be monitored in the long run, and they should be made to have proper catch-up growth with proper nutrition. Otherwise, these microcephalic babies who don't have a proper catch-up growth can end up with neurocognitive issues. And with these stunted growth and small babies, they do have a lot of emotional and behavioral issues, which are really studied in extensively these days about these IUGR infants. But there is a little bit of a balance here. So the catch-up growth, which we talk about, is is actually overzealously done in a lot of centers, and they go up from their whatever third centile to up to 50th to 60th centile with a lot of fat and calories, which we know that with all these Barker's hypothesis, which that should be nicely balanced so that these IUGR babies don't end up with these adult chronic diseases, which we see in all the studies like increased adiposities, cardiovascular diseases, insulin-resistant diabetes. So they come with a huge package of problems. So it is very important that we deal with these babies antenatally very well, so we can get some good weight babies.
So small but huge problem. Dr. Subha, you've got some experience from having been trained in Canada and worked in various setups there. What do you think? What is your impression, and why do you think, having been here and there is some differences in outcomes at a practical level?
As we said earlier in the studies, there is a very marginal drop in our low birth weights here. But I wouldn't say it's not only that, it's the post immediate or perinatal and neonatal management of these neonates. So, which is very important, which I think has to improve a lot in our setup, which we can actually do because a lot of centers are improving really well. And I don't know, this was in the article which I read with Dr. Butt's review, which said that most of our low birth weights are term intrauterine growth retarded babies rather than preterms, which now have improved with all this infertility and twins, where we are seeing a lot of preterms who are low birth weights. So which can be really addressed because with term IUGRs, we can improve with a lot of antenatal changes, which can improve the in utero nutrition and improve that. So that I think can be really handled. The other chunk of babies, which we are facing a lot of problems with, which Dr. Sajid also would agree, will be our late preterms who are SGAs, because they are treated as near terms, and but they are not actually acting as terms. They have, on top of their IUGR issues, they have their prematurity issues too. So that actually multitudes their problems and morbidities in the long run. So, but if you take in the West, so the biggest thing there is the National Neonatal Network. So we have the level 1 centers, the level 2 centers, and the level 3 or tertiary care centers. So any baby with a particular antenatally, with a particular weight cutoff and a particular gestation with imminent delivery are transported to a level 3. So right from the perinatal period, these babies are taken care of in the right path. Like perinatal events are less, and then transfer to the NICU, nice monitoring, catch-up growth is being monitored really well. So that is the biggest, advantage there, which we can actually do, because most of our low birth weights are IUGRs, which we can say are not, all of them are not the sickly small ones. So we can, by just doing simple measures, we can improve their outcomes, like training nurses or healthcare professionals who are attending deliveries for low birth weight, teaching them how to prevent hypothermia, how to basic NRP for all the nurses. Those things itself will actually capture all the, perinatal events. And then NICU care is, early feeding, preventing hypoglycemia. So this simple measures can actually help a lot of our low birth weights have better outcomes, even though we have a lot way to go.
Sorry, thank you. I think the reason we have got so much of interest in this area is because it is definitely an important area, but it is a challenging area. And we have got a vast majority of our patients are socially challenged, financially challenged, have educational problems. And if you look at our data, there is a combination of pre-existing medical conditions that our patients come with, and a good proportion of our women are anemic, they are overweight, there is diabetes. And we also have a lot of our mothers, if we look at the recent data, they actually have got no schooling, which is the color in red. And added to that, we have got all our adolescents who are widely distributed in all our different states, with the poorest and the richest having, a very wide divide in our states all over the country. So I think it must be a very challenging task for the UNICEF, and Tamil Nadu government has implemented a lot of good measures and systematic antenatal cards with a lot of information being given. Sir, what would you like to tell us? Because somehow, unless we start pre-pregnancy, we are not going to make things better. What is your experience, and is there any care models that you think we should be aware of as a group of obstetricians and neonatologists that we should try and emulate in all our setups? Over to you, Dr. Ashipur.
Thank you very much, Dr. Lakshmi. And before I begin the presentation, just to once again say Happy Newborn Week to all. And of course, this is a week to remember newborns, particularly newborns who are not able to make it past the first month, the newborn death, which is which has tremendously reduced in India, by the way. It's currently, of course, compared to the developed world, it is a bit high at 23 per thousand live births, but considerably reduced over the last 2 decades. And low birth weight also, by the way, you have seen those graphs in NFHS, it has reduced from 25 to 20%. It looks a small decrease, but you have to take that into the context of us having 30 million annual deliveries in India. So if you translate that 25% to 20% reduction across that annual delivery, then it will be a significant reduction. And all of that is, of course, happening due to many reasons, from policy, budget, infrastructure, health service, up to the laws. But the most critical input is the contribution of healthcare providers, nurses and doctors and specialists, who are the final, interface with the client, with the mothers and the newborn. So this is also a day to celebrate healthcare providers, including neonatologists. So I want to begin with that. In terms of nutrition is a continuum of care and a lifetime issue. So when we talk of nutrition, it begins from conception in utero. It includes also the issue of IUGR and the issue of low birth weight, and then childhood nutrition, which translates to adolescent nutrition and young adulthood. And in fact, IUGR, one of the things they say is it's a generational issue. So low birth weight, babies turned out to be stunted children, and then adolescents who are malnourished. And then when they become mothers, it has a generational issue. So the intervention is also very, very important to be across the continuum of care. There are many things that healthcare providers can do, but we have to do it simultaneously across the life course, meaning during pregnancy, for example, we have to ensure that pre-pregnancy, the mother gets into pregnancy with a plan. So it should be consensual at the right age, selecting, both couples, deciding the time when they are going to have the child. And then there is the issue of spacing pregnancies, at least 3 years in between, if not more. And then, of course, one pregnancy happens during pregnancy. Of course, issue of nutrition is very important, including management of anemia. We have reduced again significantly anemia in India, but we do have a significant burden of anemia, which is about 50% plus. We have the solution for that. But unfortunately, during antenatal care, for many reasons, still iron folic acid supplementation, as per the Government of India standards, coverage during antenatal care is very low. So that is definitely one area where we need to improve. There are dietary norms, dietary habits, dietary cultures. There are a lot of things that need to improve. Those are about information. Our mothers do not have, most of the time, the correct information about the important dietary nutrients. And of course, there are other factors. So diet is important. Adequate rest during pregnancy is another information that our mothers and our families, of course, their families need to receive, because there is a minimum amount of daily rest that a pregnant woman should receive. Vitamin, folic acid, and other supplementations as required and as the national standards, those are important. And then during labor, of course, ANC, management of high-risk pregnancies, is another critical factor. including diabetes, hypertension, and so on. And now detection of IUGR and timely delivery is also, of course, has been indicated very, very important. And of course, intrapartum care of IUGR suspected babies is very, very important. Probably referral of such mothers to centers where there is good delivery care, but more importantly, also linkage to newborn care. I mean, quality newborn care. And in terms of atraumatic delivery, low birth weights need to have atraumatic delivery and care during ensuring that how we deliver, the duration of labor and those things, and detection of fetal distress, management of asphyxia during labor, prevention as well as management of asphyxia during labor. But more importantly, two critical issues also during, which are available to us, but unfortunately, when we look at the statistics, we are still need to do a lot. One is the issue of interventions such as kangaroo mother care, which is available, including at community level and facility level for preterm and low birth weight babies. Most of the information and the evidence for kangaroo mother care comes from India. Indian science has produced that. Unfortunately, when we look at the coverage of kangaroo mother care for low birth weights, we are still have a gap, a lot of gap to go. And in terms of another key intervention is breastfeeding. I mean, of course, there are a lot of
I'm
other
sorry to interrupt. So I put a breastfeeding session at the very end so that there will be a flow. Just to start with, there are some models that you were mentioning in Maharashtra about how we are looking at pre-pregnancy intervention. And then we thought we will go through the pregnancy pathway, and I'll put the question of breastfeeding to you at a later stage. Is that okay?
Sure. Thank you. Thank you. So in Maharashtra, UNICEF team, I mean, the government of Maharashtra, and UNICEF is providing technical support, is piloting a community preconception care model. So basically preconception care as a care, it has been there for about 30 years or more. But community-based preconception care is a bit of a novel that government of Maharashtra is modeling with technical inputs from UNICEF, led by Dr. Kanindra Buyan, UNICEF health specialist. So this is looking at, piloting in sub-district, at the sub-district level, with community level interventions on preconception care, including delaying the age of pregnancy up to 18, iron folic acid supplementation, and ensuring anemia is prevented before pregnancy. Checking the birth weight, managing chronic complications, and so on, to one subgroup, and another subgroup taking the traditional care. And they are producing very important results in terms of reduction of complicated pregnancies, in terms of birth outcomes, including low birth weights. So we are currently advocating, for scaling up this preconceptional care model, because the clinical preconceptional care model, as you know, may not be accessible to rural mothers and pregnant mothers in the communities. So this model, we feel, can be delivered through sub-centers where ANMs and auxiliary nurse midwives and ASHAs, accredited social health activists at the community level, can advocate for it to rural mothers during pregnancy. So this is one model that we are trying in terms of preconception care in Maharashtra with the government of Maharashtra. Thank you.
Thank you, sir. So really, to focus well before pregnancy is the way forward to stop the big problem from happening thereafter. And I think from what you've told us, any of us who receive a wedding invitation should remember to, in a very gentle way, see if this particular couple who are going to be married have understood that, health well before pregnancy is the most important thing for a successful family. We'll just move on to the area of detection of low birth weight and then come back again to discuss the postnatal issues. I'd like Dr. Manomani to highlight to us the role of gestation determination and the role of history taking, because though these may be simple things, what is the type of challenges that we face in our setup? And coming from big institutions and having large catchment areas, do you want to highlight us about the role of these two areas, gestation determination and history, for low birth weight determination.
Good evening, and thank you, Lakshmi, for the opportunity. So the role of gestation determination, so to define whether the baby is growing as per the gestational age, because as per definition, it is not having its potential. So we need to have definite last menstrual period and what is gestational age, so that from the history we have to ascertain is the LMPs a good one. So for that, patient should have a regular menstrual cycle, and if it will be good, the patient has got a first trimester, especially 8 weeks scan, or to confirm that her LMP is correct, and at gestation age we can calculate as per our LMP. But many a times patient coming from low socioeconomic status, some of them may not remember the LMP correct, and if they are obese, or sometimes if they don't have irregular cycles, we may not be able to rely upon their LMP. So if we go by the LMP, we may be missing, or they have be wrong dates, and we will be branding the baby as a low birth weight even though it is conceived late. So for that, gestation determination is very, very important. But that's why even in the primary health centers, in the block PHCs, government has given scan training to the medical officers, so that they do basic ultrasound during the first trimester, so they can confirm gestational age, whether it is growing, confirmed to the LMP, and we should take whether it is the regular conception, or it's a spontaneous cycle, or if it is a infertility treated cycle, or IVF conception. It is very good. We'll be able to have the exact date of conception with IVF ET. From the menstrual cycle, we have to have the history. We should have a regular cycles, normal flow, so that we can rely upon the LMP. So gestational determination is very, very important when we are going to manage the low birth weight babies at a later date. So we cannot be going on changing the gestation age as the pregnancy advances, because the first trimester ultrasound is the gold standard for determining gestation. So it should not be changed after the beyond the 12th week of ultrasound. So based on the 20th week, 24th week, we shouldn't going on changing the we should not be changing the gestation age of the baby. So history taking and documenting the LFP and confirming is it correlate with the scan. It's very, very important for managing the delivery at a later date, especially for the low birth weight babies. So I think
from history point of view, I've just put out a list, and at a practical level, when there are large volumes of patients sitting in an OP, now we have antenatal cards and there is a checklist. Are we able to look through all the various causes, and is the system being effective for us to do a history-based triage?
Yes, from history-based, because low resource setting, we cannot be having all the biomarkers and the regular scans to pick up the high-risk patients. So from the history, whether based upon the patient's, depending on the patient's age, and whether it's a previous medical disorders, or the patient has had a pre-eclampsia, or small for gestation age baby in the previous pregnancy, or whether she had eclampsia, or whether it was a preterm delivery, and where was the delivery, what was the birth weight, everything regarding the previous obstetric history in the current pregnancy, whether she is in the normal BMI, if she is going to be low body mass, undernutrition, or overnutrition, again, patient will have complications. And is there any first trimester baby? If she had done any of the biomarkers, it will be very good. But in a low resource setting like us, we cannot expect all the patients to have all the biomarkers, Papa A and beta SCG. For at least in the first trimester and the second trimester scan, we can go for uterine artery Dopplers whenever chances occur. So from the current pregnancy, again, we should rule out anomalies, and if there are multiple pregnancies, we have to be cautious that she will land up in a preterm delivery or with a low birth weight. So all this history, whether a previous stillborn abruption or any pre-eclampsia, eclampsia, and if the mother or father is, they themselves are the low birth weight babies, so they'll be producing again as per genetically, they'll be having the present babies also the low birth weight. And present pregnancy, if possible, we can go for low PAPA and AFP and PLGF. But all these things, serum biomarkers, again, as you already pointed out, financially, we are all the patients cannot spend this much amount. So we should go for the recurrent previous history. There is a small for gestational age. Then we can go for the repeat recurrence and 20% in the present pregnancy also. And even the low risk primary, there will be a 5 to 10% chance for small for gestational age and somewhere around 4% in a multi. So in a multi-gravida, we should be going for previous obstetric history, whether there were any complications and what was the baby weight, where was the delivery, how was the delivery, what was the duration, everything should be documented so that we'll be prepared to deal the complication during this pregnancy. So that some studies have come out, so what can be given during the first and second trimester, how to pick up these patients. So we have to triage them based upon the history as well as present pregnancy, whether they are low risk or high risk. So we should have a document the first booking visit. Is there any complications, medical complications? Are there any previous problem during the preeclampsia and the previous pregnancy? So document what is the BMI, and we should look for the weight gain. So this should not be a complete weight gain for throughout the pregnancy, whether she is gaining adequate weight, that is half a kg per week or 2 kg per month, whether the weight gain is adequate in between the checkups, subsequent checkups, whether she is gaining weight. And if there is more weight gain, we should be cautious that there is occult edema, she might develop preeclampsia in the subsequent weeks, and we should look for the proteinuria. And we should have a first trimester scan to dating and confirm the gestational age, and the subsequent to rule out anomalies in the second trimester anomaly scan, and with a uterine Doppler uterine artery Doppler at 20 to 24 weeks. So this along with the if the biomarkers Papa A, beta SCG and PLGF with the uterine artery Doppler and our clinical examinations, it is picking up preterm delivery as well as preeclampsia in the less than 34 weeks. We need to have some number needed to check somewhere around 10. Then we can be cautious that these patients might develop low birth weight. And as per the aspirin trial, we can start them with low dose aspirin from the 16 weeks onwards. So this is what the latest studies have said. Age of obesity, with the history of obesity, primary and the Asian population, and if there are any medical disorders of hypertension, autoimmune disorders, and APLA, SLE, thrombophilias, and current pregnancy for 20 weeks, uterine Doppler, PI, and PLGF is present, we start them with aspirin 150 milligram daily at bedtime, starting at 12 weeks of pregnancy up to 36 weeks. We have the studies have shown that there is reduction of 82% less than 34 weeks preeclampsia is being prevented, and 62% of them when it is less than 37 weeks preeclampsia is being prevented. So that if we have these biomarkers in the first trimester booking visit, if it shows it is high risk, or if we go by the gestosis screen, whether there is 3 low risk factors or 1 high risk factors, we can start them on aspirin. So that low birth weight as well as preeclampsia, and to treat preeclampsia, the medically indicated preterm deliveries could be prevented. So this is what our aspirin trial has come out. So if there are these history-wise as well as the current pregnancy screening show some, if it is becoming positive, it is better to start them with aspirin 150 milligram at 12 weeks of pregnancy itself. If we start them after 16 weeks, the results are not this much good. So it is better if we can start them at 12 weeks. So the first trimester booking visit, history taking, and BMI and examination and the previous obstetric history, it holds very, very important pathway, as well as if they are anemic, we can correct the anemia so that the low birth weight babies are being reduced.
Thank you, Dr. Manoharmani. There is also now some large data coming out about how patients' anxiety and, emotionally not coping well also is a very big factor for growth restriction. So I think apart from taking the medical history and obstetric history, also taking a mental health history for these patients and assessing them is quite important. Thank you. Now, aspirin has become our wonder drug, and I think thanks to aspirin, we feel we are able to make some difference. But like what we have discussed, we need to screen them early. So we have to see them in the first trimester. Where facilities are not available, we can do a history-based screening. Where facilities are available, we can go with biomarkers and uterine artery Doppler. Obviously, clinical examination is always the cornerstone, and measuring the fundal height, documenting it on a chart is really the cornerstone, because most of our patients we are going to now identify in the low resource setups on clinical examination. Dr. Manonmani, briefly, do you want to tell me how do you think it has evolved over time? Is clinical examination proving to be a good trigger in your setup to create awareness of low birth weight, and is that then leading to further detection?
Actually, what is done in a primary health, again, the patients are being triaged, whether they are low risk or high risk. So based upon history, if they become high risk, they'll be referred to CMOC centers or the tertiary care centers. But the low risk women, as already pointed out, 5 to 10% of them may develop IUGR. So for detect them, to avoid the perinatal morbidity and mortality, we have to go for, first and foremost, is our clinical examination. As you pointed out, simplicity of fundal height. So it correlates from 20 to 36 weeks in centimeters. So the VHNs and the ANMs are being trained the low risk pregnancy. So they have to measure clinical examination is the teaching from 12 weeks, 16, 24 weeks up to 36 and comes back to our 32 weeks. So this is our mantra to detect the low birth weight babies. So they should be having the clinical examination. So if there is disparity of more than 2 weeks compared to the previous checkup, they should be alarmed. So it should trigger the alarm that this baby might go for low birth weight. So again, they call them back, or you confirm with your ultrasound biometry if it is available, or not, you call them back again. So it should be plotted in the gravidogram. And if there is at any given time, there is a 4 weeks disparity, immediately they should refer the patient to the tertiary care. Or if they suspect, they can call them back and do again and refer them back. And if the ultrasound biometry is available, it's very well and good, so that we can diagnose if it is falling less than 10th percentile of the growth potential, then we can initiate all our protocols and follow those babies. And out thrice once in 3 weeks, we have to go for the biometry, and once in a week what is needed according to the gestation age, because we are very afraid that if the babies deliver in a small setup, if the babies may not survive. So we need to plan where the delivery should be, so that the babies are given a very good care, and we need an intact neural as well as all the organ intact development should be there. So we need an intact survival of the baby. Not only we need the babies to survive, but we need to have the intact survival, because patients having a low birth weight baby, having the trauma of making the baby to grow, it's very big. So again, if they have a previous one low birth weight baby which had a treatment at an NICU care, where a prolonged care, whatever is said and done, it is very traumatic to them. So they need to have a average weight baby, take home baby after delivery, depending upon either 2 days or 3 days, depending upon the delivery. So they don't want to spend much of time in a NICU if given a chance. So at whatever given said and done, they need to have a good baby at their hands at the end of the pregnancy. So in that case, we have to identify and make them to go whatever weeks, from 28 to 30 or from 30 to 32, we should give them the advantage of those weeks. So for that, we need to have the physical clinical examination, and it should be followed with the backup of ultrasound.
Thank you, Dr.
That's what you have to do. But
what we know is that even when we do ultrasound, we are not accurate all the time, isn't it? And what we know is that there are lots of different graphs that are there. And if you look at, we can actually customize for our own population that I have done here. Or you can look at the Western Hadlock graph or the South Indian population, which the Sonocare software gives, and the newer studies which have looked at multiple countries and the intergrowth. So at each centile, there is different weight cutoffs that come based on which chart that we use. So just doing the scan is not enough. We have to understand which graph will suit us. And to add to that, we have got some customization also that has been tried, where with ethnicity, if we change and customize, whether that makes outcome. And when you customize the graph and then you plot the weight, you will identify which is the average for that particular patient. So there are multiple concepts in the charts itself. But the ideal way is to give a report like this, where you've got all the biometry measurements, you've got the centiles, you've got the graph. Is this a world we can aspire for by 2025, or are we far from this in the current situation? Are we able to create systems where this can happen?
Yeah, if it is, we can achieve this, it is very, very well and good. But within, now we are end of 2020. So within 5 years, we could train all our obstetricians as well as radiologists, and with the load of patients what we have. For a single center, we are having nearly 900 deliveries per month. So roughly 30 deliveries in an average center of a medical college. But if you take IOG and all, we are having deliveries somewhere bordering around 70 to 80 per day. So imagine the load of the antenatal mothers, what we are going to have. So for patients, can we have this much of expertise to have and chart it out? It would be very, very best. But I don't think it is possible to achieve 100% achievement is possible for everyone by 2025. But we should strive to achieve this. So that will give a better result if you can do this. But at least not for every, at least one single scan should be done with a proper anomaly to be ruled out. And at least we can have a growth chart at 20 weeks, so that by clinical examination and for a, if you identify clinically, we can immediately have to send them for further confirmation and management in a concerned centers.
So we will focus on good triaging, but we'll actually have to now, like how we spoke about pre-pregnancy stabilization of health, I think all our PGs also must be given the training so that as they evolve and become practitioners, this sort of systems can become much easier to implement. Dr. Subha, what do you think? We give all these graphs to you and then you give us some graphs afterwards. Do they all correlate? Dr. Subha, do you want to just check your mic is on?
Yes, it does, but it is so variable, Lakshmi. I think a lot of times we ourselves have had a lot of controversy of you calling a child SGA, and I'm saying, no, it's adequate for gestation after birth. As you said, you also have a lot of different graphs which you are using, and I've also done a little bit of a study saying what are the antenatal graphs which you use, which can correlate with our postnatal charts. But I think in the literature also there's been a lot of ups and downs or going back and forth about which charts will correlate for, will accurately tell whether a child is SGA or growth retarded, which will also take into consideration the, ethnicity, race, which actually plays a huge role in saying whether it's an SGA or an AGA baby. But for postnatal charts, we've been using Fenton's, and I did discuss with Dr. Sajid also. I think they're also using the Fenton's charts, which has gender-specific graphs with all the anthropometry on the same chart, which we can use up till the 50 weeks of corrected gestational age. Why we use it is because we are seeing a lot of preterm or late preterm low birth weights these days. So we are able to plot them periodically till about 50 weeks corrected gestation. And then we can change over to the IAP WHO integrated charts, which has, weeks on which we can plot their growths after that. So this has been correlating pretty okay with most of our births, I would think.
So we have got a complex problem of not having sufficient intervention before pregnancy, which contributes to the small for gestational age. And then we have got some inadequacies with ultrasound service. And then we have got some lack of correlation between the various charts. So there is still some more scientific advances that are needed for clarity. So perhaps then going back to 2.5 at term is the best way for us to focus on care for the right group of people. What is your take on customizing a chart versus universal chart, Dr. Shiva?
So I was doing some reading up, and it says this customized chart. I think you had put up the intergrowth growth charts also in your table along with the Hadlock. So there itself, we can see a huge discrepancy in the weights for a 32-weeker, for example. If you take, there is a lot of discrepancy. So if I go back to that slide, which on which they had told us, this was a nice point I wanted to raise. The next one. The next one, this one. See, they say just a 200-gram difference in the birth weight of a baby is enough to say there's a 60% chance that you can, misname the baby as an SGA, even though it's an AGA. That's a 60% chance. But if there is a 400-gram difference from the antenatal assessment or just between different ethnicities, like a Indian versus a Western child, if you have universal growth charts and do not have customized growth charts, then a 400-gram difference between two babies can label the higher baby as an AGA and a lower baby as an SGA, even though for that ethnicity, that baby may be inappropriate for gestation age. So I thought this was a very interesting finding, and this is the key to say that we have to customize charts based on, ethnicity and race and a lot of other factors also. You might be the best judge as obstetricians, like maternal height and maternal build, with all that factors which might influence the baby's birth, which might not be a pathological SGA, but might be just a small baby for the mother.
Thank you. So what we know is customization has got a lot of champions, but equally some people who don't think that it makes a difference. So I think there is still some debate which may be better, but surely for a small built Asian mother, we are not expecting a big baby. But we have got the other side of the coin also, Dr. Manonmini. Are there a good proportion of mothers who are completely unbooked? For example, have had no care. Would that be, say, for example, 2%, 3%, 5% of your population?
But actually, as of previously, it was like that. But as of now, the government is giving that Muthulakshmi Reddy maternity scheme. So they are giving somewhere around cash of 12,000. 14,000 and again 4,000 worth of all this nutritional kit. So the low socioeconomic status patient, because to all the analysis of maternal deaths, the government has come out with the idea that to make the patient to come for the institution deliveries, wherein Government of India gives 700 rupees for the institution delivery, Government of Tamil Nadu has given this Muthulakshmi Reddy scheme, 18,000 rupees during delivery, postpartum until the first immunization. So patients in especially in the lower economic strata, they are very well aware of this. So they are coming now for initial booking itself. Though only in the patients coming from other states or in the very remote tribal areas, they are not getting booked. And one more thing is now they have to get the pygmy number. That is pregnancy infant cohort monitoring and evaluation. And with that, they have to get a RCH ID. So only by giving these two numbers, they will be able to get the birth certificate, or else the birth certificate will not be given. So the government has made this point so that they are getting the numbers, pygmy numbers, and getting the RCH IDs so that they could get the birth certificate. So for this, carrot is being hung before them. So they are coming for the initial booking, especially they have to book by 12 weeks. So that all the PHs are being given all the basic investigations. So the anomaly picking up rate is very good, as well as maybe very few are being left out. And the VHs are going for door-to-door survey at times, and they are picking up all the cases. All their maternal deaths video conferences, they are being questioned why they are not booked in time, and why it is being, all the high risks are being missed out. So now the government has given such an importance for the maternal health. So the booking is very, very good. Maybe 1 or 2%, especially in the remote areas where they are not accessible, but even then they are getting booked. So that is what scenario now. From 2018 onwards, this pygmy number and RCH IDs must for all the birth certificates. So every pregnancy is getting registered. Maybe probably our ectopic pregnancies are very early, from 40 days, 50 days, 60 days, or unwanted pregnancies. We have to put it that way. The wanted pregnancy, they are getting booked. Sometimes they want to hide the pregnancy. Those cases only are getting missed. This is what the scenario.
Now we have got scenario where only sometimes you're seeing this, but in large centers, I'm sure there will be some numbers that are coming through, Dr. Shajit. How do you assess the gestational age in a patient for whom we are not sure and we hand over the baby to you?
So as Dr. Manohar was telling, the best would be to go by the dating scans. And if not possible, we go by the LMPDD that is accurate. And in our newborn setup, we go by the New Ballard score, which looks at two domains, the neuromuscular maturity and physical maturity. And based on the score, we signify the gestational age of the baby. But there can be some situations, especially in the community level, where we are not able to assess for the gestational age or the birth weight, especially in unbooked pregnancies, which might be very low number at present. But we do have some surrogate markers for that. So these surrogate markers, can you move to the next slide? Yeah, so this is the Fenton. This is again the ideal one, as Dr. Subha was telling. This is the app in which we can plot the baby's weight and see if it is falling at AGA level or SGA or LGA level. Next slide.
Sorry, I've moved it to the newborn care period, sir. I'll just put that question to you.
So the surrogate markers that we have are, we look at foot length of the baby. We look at the chest circumference, and we look at the other parameters like this chest circumference and foot length have been found to be matching with the birth weight, though not accurately, but to an extent. Any foot length that is less than 7.7 centimeter, and any that is
chest diameter.
Yeah.
30
so
centimeters.
Any foot length that is less than 7.7 centimeter is significant, and that signifies a baby could be SGA baby actually at the community level. That is at the community level where we do not have charts or the accurate devices to find the that is whether the baby is AGA or SGA.
Because we are coming to nearing the end of the session, we'll keep all our answers brief. One important area, Dr. Mananmani, is the intrapartum care. Even if we do not detect, we got to be very careful when they are clinically small to provide the proper intrapartum care. What about CTG monitoring? Do you see that being important, and do you see that being implemented well? Because we don't want a small baby who's preterm and asphyxiated, because that becomes more than a triple trouble, isn't it? How is the monitoring for low birth weight at your institution?
The baby is going to be low birth weight, and especially with IUGR, the oligoamnios and all, we go for continuous CTG monitoring. Even with the adequate, with the restricted resources, it is being triaged. The low risk, we go for handle Doppler, but when especially it is a low birth weight and if there is oligoamnios, we are going in for the maximum continuous CTG monitoring with the available resources. And partogram, it is a must for all the babies. So if there is, because all this low birth weight will be referred to the tertiary care, so all those these babies come to the tertiary care. So we go with the maximum continuous CTG monitoring as well as their partogram, so that any given time if there is a delay in progress as well as any problem in the fetal heart, we take them for cesarean section, so that they are not again given the extra burden of perinatal depression again. So this is what we do.
Thank you. Now, newborn care, we have already gone through the risk factors that they have, and we know that there is a lot of problem with mortality of our Indian babies, and that's what we have discussed. And we have also discussed the timing that the mortality happens within the 1 week after the birth. And we know Dr. Shajit has put this slide for us to say that we need a multidisciplinary approach when we are looking after a low birth weight baby. Dr. Subha, what would be your day 0 checklist for a low birth weight? And we will only give you 1 minute for this answer.
I think I've gone over the whole checklist in my initial slide itself. It's just to revamp the whole thing, that proper personnel for resuscitation and temperature maintenance in the case room or in the at delivery. Look for congenital anomalies, which is an association with IUGR babies. Follow up all the metabolic parameters in the NICU. which I already said, sugars, calcium, and other polycythemia, and they are very prone for infection. So, be cautious and vigilant for infections, and long-term follow-up. That's the only the day one checklist. And feeding issues, breast milk exclusively because the higher chance of NEC. Monitoring at least for 5 to 7 days, because most of our small babies, they are up, the sugars are normalized, the metabolic parameters are done by a week, unless the smaller ones and the sicker ones definitely seem to stay for a longer time. Because as we see preterms, we see more very low birth weight, extremely low birth weight, which take their time to go home. And long-term follow-up will be all their anthropometry for their catch-up growths and for neurodevelopmental as well as physical growth.
We will give that part to Dr. Shajit. What are the steps that we have to take in the subsequent care to minimize their morbidity and mortality, please?
Yeah, ma'am. So there is a need for follow-up of this low birth weight babies, because these are high-risk babies, because the immediate outcomes might be good, but the long-term outcomes may fall short. And the short-term outcomes may not give us a proper what these babies are going to go, how they're going to behave in the long run. So we don't have a proper database in India. So what we do is we do, this is the AIMS schedule, that is which we follow in most of the places. So baby who is less than 1,500 grams or less than 32 weeker, we assess the baby after discharge. We look at the baby again at 7 days of life, then again at 2 weeks until 3 kgs. So every 2 weeks until 2 kgs. In other conditions, there is a baby who is more than 1,500 grams or a SGA baby. We look at the baby again at 2 weeks after discharge, and again when the baby comes for immunization at 6, 10, and 14 weeks of chronological age. So again, we assess this both the set of babies at 3 weeks, that is 3 months, 6 months, 9 months, 12 months, 15 months, and 18 months of corrected age, and then every 6 months until about 8 years of age. So there's very important to assess this baby's development at corrected age, because they fall short otherwise. Now, this is the protocol that we follow at every follow-up. We do a medical examination. We look at their nutrition and growth and whether they have been immunized. We look at the neurological examination. We do a developmental assessment. Development assessment is done by screening tests like Trivandrum Development Screening Chart or Denver's 2, and the assessment proper is done by Dasi or Bailey. And we do an ophthalmologic assessment for squint and refraction errors, hearing and language and speech problems, gross motor function, and we look at their behavioral, cognitive, and intelligence status. So all this is done at every follow-up, so that we don't miss, and we institute what is called as early intervention. The early intervention helps to cope up with all the deficiencies in the domains that they might have. So, so this is what we do in every follow-up. So these are all complications that the preterm baby or the low birth weight baby has. All this has been already mentioned by Dr. Subha. So these are the long-term complications. Again, that has been told by Dr. Subha. Yeah. So following up these babies periodically is very, very important. That's what I would like to stress upon.
Thank you. Now we will have Dr. Ashibish share his experiences about what the organizational factors can be that can influence low birth weight outcome. And with that, we can draw this panel to an end. Sir, you mentioned about breastfeeding. That is a huge challenge, because if you look at our recent reports, 57% of our children were only breastfed within 1 hour. 58% had exclusive breastfeeding at 6 months. So these two are very important things that we have not done well at. So can you kindly tell us about breastfeeding in the public health perspective and other organizational things which are challenging, because nutrition is absolutely important and we have to provide care in a setup, in a systematic manner. Over to you, sir.
Thank you very much, Dr. Lakshmi. Indeed, breastfeeding is one of the simple and straightforward interventions in which we are not doing much. This is of relevance to all newborns, by the way, not just low birth weight newborns, but for low birth weight newborns, this is particularly important, not just for nutrition purposes, because of the many advantages of breastfeeding, including immunological protection and the higher risk of infection in low birth weight babies, as you all know, be it the IUGR babies or the preterm babies. and many other advantages. Now, one issue is the issue of information, of course, for mothers, be it right information, which empowers, but disinformation also, which disempowers. Like, I mean, bottle feeding is good, and I mean, access to many other disadvantaged information, which as healthcare providers, we should be protecting our clients. You know, one of my responsibilities when I was obstetrician was to protect my clients from misinformation and inappropriate practices. And one of them for me was very clear, was bottle feeding.
And I think, like what you mentioned at the beginning, the family plays an important role, so that we ensure the family play a positive role in this matter. And that will also help, isn't it?
I mean, I regard the obstetrician, the midwife, and the neonatologist as the extended family of the mother and the newborn. We are the extended family. We are the ones that are available at the most difficult part of their life. Labor is the most difficult part of a woman's life. And it is the obstetrician who is there and the midwife who is there throughout labor, not the other families, by the way, who are supposed to be blood relatives and so on, you know. When a newborn is having asphyxia, it is the neonatologist that is fighting there for its life. And that is the family. So we need to support with breastfeeding. Another key intervention at this time I would like to stress is kangaroo mother care, which we are not doing well. We talk about, of course, we would like our babies to have incubators and many other interventions, but this is easily available and it has proven benefits for which are of advantage to the low birth weight babies, but for all babies, but for low birth weight babies. So we need to do more that. Information, spacing, documentation. Documentation is another area where we need to do a lot, because why we don't have data is all data begins from doctors or nurses. It is us who correctly measure one data and document it. For example, birth weight needs to be measured. We have to ensure that the measuring scale, I have told you many stories about my experiences about measuring scales in our labor rooms and how they can be, you know, misguiding us if we are not careful, and then documenting it. That is the beginning of all data up to the national level that we see or don't see. So that is our responsibility. We begin there. So as specialists also, we have to ensure that all providers under us respect, take the measurement properly and document, including the ultrasound, including everything that we have been discussing so far. So over from my side. Thank you very much.
Thank you, sir. So thank you all panelists. We are coming to the end, and I'm sorry we have overrun by 10 minutes. But I think we have looked at all the very low-tech interventions that can make a huge improvement, but a lot of social input is required. And I think when we talk about a joint care between obstetricians and neonatologists focusing on low birth weight, we need to detect them well with ultrasound and then follow them through with good newborn facilities. Thank you, everybody. It has been a wonderful panel, and thank you, NNF, AICM, and UNICEF for giving all of us our opportunities. Thank you to all the panelists.
Questions? We have time for questions, Lakshmi? Somebody's raised a point about questions.
For me, what about the organizers?
Yeah, you can take some questions if you have time.
Where are the questions?
Thank you, Lakshmi and the AICM Foundation and UNICEF for this wonderful opportunity to be a part of this program. Thank you so much.
Thank you, Dr. Manonmani. Do you want to just stay and we'll see if there are some questions that are coming?
Yeah, definitely.
Is there anybody who's able to access the chat box? I am not able to.
No, there don't seem to be any questions as it in the chat box.
You can see if there are any from the floor.
There is no question as such.
Dr. Lakshmi, do you want to ask any questions, or any of the members who put any questions through to you?
No questions have come as far as I am concerned.
Mr. Kaushik?
No, ma'am. I was just wondering if we have if there are any questions from the floor. If not, we can close the session.
Dr. Lakshmi?
On behalf of NF, I'd like to thank Lakshmi and all the panelists. It was an excellent panel and very informative for both obstetricians and neonatologists. Thank you very much for taking this effort and putting it all together. Thank you.
Thank you, Dr. Rama.
Thank you very much for the opportunity, Lakshmi and Dr. Rama.
Thank you.
Bye-bye.
Thank you, Dr. Ashbear and Mr. Kausi. Thanks for being here.
Thank you, everybody.
Nice meeting you.
Dr.
Thank you,
Lakshmi,
Sajid. Thanks a lot, Sajid,
discussion.
for this wonderful time.
Thank you.
Thank you.
The entire session.
Thank you, ma'am. Thank you.
It was very enlightening, and thank you everyone for pitching in.
Right. Nice meeting you all. Thank you.
Thank
And
you.
Thank you.
Thank you so much.
Bye.
Bye.
Bye bye.
Bye. See you. Nice meeting you all.
Oh, yeah. Pleasure meeting you all.
Manu, good to meet you after some time. Dr. Shahjid, long time no see.
Yeah.
Good,
It
good.
was nice
Rajat
interacting
is
after a long
hiding in the
time.
COVID season.
I know. Nobody is seeing each other now. This is the only way to see us.
That's right. That's right.
Yeah.
One way to interact now.
Meeting at our places and meeting everyone. So it is
I
a
know.
positive.
All
Thanks
of you stay safe.
Yeah.
I know.
Thank you. Same to you.
Bye.